I'd like to thank everybody for coming. My name is Scott Deviney. I'm with ETMC Orthopedic Institute. How many people out there have knee pain?
Just keep talking.
Quite a few. Quite a few. And that's why we're here to talk about different treatment options. And we're going to go through everything from conservative to surgical options. You got it?
Yeah, just keep talking. Just keep talking. I got it.
So arthritis affects over 70 million Americans. It's a leading cause of disability. 1 million new patients are diagnosed with arthritis each year. Of these, 50% are 65 years of age or older. How many people here are 65 or older? All right. There are different forms of arthritis. Okay, osteoarthritis is the most common. It's the wear and tear type of arthritis. There's also rheumatoid arthritis. It's an inflammatory arthritis. It's a systemic disease, affects multiple joints. There's post-traumatic arthritis. Maybe you've had a previous fracture or cartilage damage. Inflammatory arthritis, like I said, rheumatoid is the most common. There are other arthritises out there, such as gout, pseudo-gout. I saw Phil Mickelson on TV last night. He was talking about his arthritis, psoriatic arthritis, and the treatment for that. And septic arthritis. If you've had a previous infection of the joint, this can destroy cartilage. So here's a picture up here. That is the top bone or the femur, and that's normal cartilage. Here's the bottom bone or the tibia. This is the meniscus, kind of a C-shaped shock absorber that sits between the bones. Well, here's a picture of an arthritic joint. The cartilage is worn out, and you're looking at bone here. So all the arthritic symptoms are from lack of cartilage. Factors that influence the onset of arthritis. Well, a family history, especially in the inflammatory types of arthritis like rheumatoid arthritis. Age. If you're over 45 years of age, you're at risk for developing arthritis. Weight. If you're obese, you're at risk of developing arthritis. For each pound that we're overweight, that puts 4 pounds of extra force per step on your joint. So if you're 30 pounds overweight, each extra step puts 100 pounds of force. Gender. Females are more oftenly involved than males. Trauma and repetitive stress. If you're a professional athlete, you had a lot of wear and tear in your joint, you may well develop arthritis later. Look at Earl Campbell. High impact sports. A lot of wear and tear in the joint, you may develop arthritis. And other illnesses. Maybe you developed a septic joint in the past where the cartilage has been destroyed. The knee is the #1 joint affected by arthritis. It's a large weight-bearing joint. It's got a complex motion pattern. There's ligaments that run on the side of the knee. There's the meniscus that are in the center of the knee, those C-shaped shock absorbers I talked about. So what are the symptoms? Well, stiffness. Once the joint becomes damaged, you may have trouble bending the joint. Swelling. Your body responds by producing more joint fluid, so your knee may be swollen. Deformity. If your arthritis gets bad enough, your leg could look deformed. You could be bow-legged. Your friends are telling you, well, you're really bow-legged, and you notice that you've developed this over time. You could be knock-kneed. That's when you wear out the cartilage on the outside part of the knee. Crepitus. Well, my knee just crunches when I bend it back and forth. It's clicking. Feels like popcorn. My husband tells me. I hear it all the time. Pain, pain, pain. Startup pain. When you first get up in the morning, it's really tough to take those few steps. And then you get warmed up, it's not quite as bad. But then you sit down, you get cold again, try to get up. It's painful. That's an arthritic joint. Activity limiting. Is it limiting the things that you want to do? Well, I'd really like to go to Walmart and shop all day, but I just can't do it anymore. And nighttime pain. It wakes me up at night. I can't get comfortable. I have to put my knee in a certain position. It's horrible. So what can you do on your own? Well, Maintain your appropriate body weight. And I often send my patients to dietitians to help out. Avoid high impact or symptom causing activities. If you're older and your knee's bothering you, you're still attempting to run, well, maybe go to a non-impact type of activity, such as the elliptiform, swimming, biking. You can ice down your joint after activities, may help. And then there's the over-the-counter drugs, anti-inflammatory agents, Tylenol, and nutritional supplements, which I'll talk about. When is it time to see the doctor? Well, if you have recurrent pain or swelling, maybe time to see your doctor. Your pain's stopping you from doing the things that you want to do. I just can't go out in my yard anymore. I can't go to the store because it's hurting me. It might be time to see your doctor. And especially nighttime pain. So what can your primary care physician help you with as well as your orthopedic surgeon? Well, weight loss. Remember what I said, each pound you're overweight puts 4 pounds of extra force on your joint per step. Anti-inflammatory agents. It's generally the first line. People will go to the store, there's Motrin, Aleve, things like that. Physical therapy, which I'll talk about. That includes stretching and strengthening of the quadriceps muscle. It helps provide stability of your knee, which can decrease your pain. And then there's injections, which we'll talk about. So, once you do see a physician, we generally get x-rays. Well, what do the x-rays show? It'll show narrowing of the joint space. That cartilage is worn down. This patient's starting to develop bone on bone. You can see squaring of the condyles. Osteophytes or bone spurs. What happens is the cartilage starts to wear down. Well, your body responds to that by forming more bone. Once bone hits on bone, it forms more bone, and that's bone spurs. And sclerosis, you'll get some hardening of the bone. An MRI is most helpful if we think that there's mechanical symptoms such as catching or locking that we can't explain, or we want to look at the ligaments, or a meniscal injury. The meniscus, remember what I said, it's those C-shaped shock absorbers that sit in your knee. Not uncommon to have a tear of the meniscus with an arthritic knee. So let's look at all the treatments out there, and they're all over. Tylenol, been around for a long time. It's not an anti-inflammatory, it's a pain reliever. The non-steroidal anti-inflammatories, Advil, Aleve, been around for a long time, not without their side effects. Physical therapy, I talked about the gentle stretching, quad strengthening, strengthening the thigh muscles can help. Activity modification. If you're doing an activity that jars your joints, you might want to slow down. Weight loss. We've talked about, I send a lot of my patients to dietitians to help out. So anything we can do to decrease the stress on the joint will help. And then the nutritional supplements. You've heard a lot about the glucosamine and chondroitin in the literature or in the newspaper, and so we'll talk about that too. So what is it? Well, glucosamine, what it does, it stimulates hyaluronic acid production from the synovium in your joint, and it can help decrease pain. Chondroitin actually inhibits an enzyme that normally breaks down cartilage. So they can be effective. There are studies out there that show they're as effective as anti-inflammatory agents. And they can also have fewer side effects. You can get some nausea, some vomiting, but not near the side effects as anti-inflammatories. So, glucosamine and chondroitin may help arthritis pain and improve function. How about the injections? Well, you hear, well, went to the doctor, he gave me an injection, pulled some fluid off my knee and got an injection. Well, a corticosteroid is a naturally occurring hormone in the body. It decreases inflammation. And you can have those injections up to 3 times a year or every 4 months in my practice. The viscoelastic series, well, that's hyaluronic acid. Okay, and there's a number of them out there, Synvisc, Orthovisc, Euflexa. They can decrease inflammation too. You know, the companies claim up to 12 months of relief with these injections. Everybody is different. Some patients say, hey, that's the best stuff ever. Other patients come back and say, nah, it didn't really help me. Bracing, especially the unloader type braces. If one portion of your knee is involved with arthritis, what these braces do is try to transfer the stress to the opposite side of the knee. Some patients love them. Other patients say, well, they kind of dig into my skin, I can't really tolerate it. But it's worth a try, it's not surgery. So when do you see an orthopedic specialist? Well, conservative treatments aren't working anymore. Your activities are limiting. You can't go do the things you want to do. Then you might consider surgical treatment. So it's altering your life. Well, then it's time to consider doing something, because we don't want you sitting around. We want you to be active. So the different options. Well, arthroscopy. You go in there and clean up the joint. You debride it. Arthroscopy is indicated for mild to moderate arthritis, especially with mechanical type symptoms. Once your arthritis gets above that moderate, arthroscopy doesn't work very well. And Medicare doesn't like to pay for it unless there's a mechanical symptom documented. Also, there's synovectomies, arthroscopic synovectomies, which I'll get into. These are for the rheumatoid patients. In rheumatoid patients, the synovium becomes hyperactive. It produces enzymes that destroy cartilage and bone. Osteotomy. Osteotomies are generally for patients 30s, maybe early 40s, when we actually cut the bone to realign it. Arthroplasty. Everybody's heard of a knee replacement. Well, there's partial knee replacements called unicompartmental knee arthroplasties, and then total knee replacements. And we'll talk about that too. So what's arthroscopic surgery? Well, you put a small camera into the joint's filled with fluid, and you remove debris and smooth cartilage. It's less invasive, quicker recovery, but it's indicated for mild up to maybe moderate arthritis in patients that have mechanical symptoms. The results, somewhat unpredictable. 50 to 66% of people get relief for some period of time, but it has to be the right patient you're talking to about doing it on. It's not going to work for somebody that has advanced arthritis in their knee. The pain relief may be temporary. Like I said, it's best for patients that have mechanical symptoms. The knee's locking up on you. Arthroscopic synovectomy surgery. This is for rheumatoid patients, right? Early stage rheumatoid patients. You go in there and resect that synovium. Synovium produces the enzymes that destroy bone and cartilage, so you resect it. It buys them time. So the potential benefits of a synovectomy is it's temporary relief for the patient with rheumatoid arthritis. How many patients have rheumatoid arthritis, or how many people have rheumatoid? So this is mainly an osteoarthritic crowd, okay, and that's the most common. So what is a knee osteotomy? Well, like I said before, it's generally used for younger patients in their 30s, maybe early 40, that don't want to alter their activities. They want to continue to jump, run. They're not going to slow down. Well, what you do, this patient initially had a deformity that went out to the side here called a varus deformity. Well, we cut the bone, took a wedge, and realigned it so the mechanical axis through the center of the joint. Then we fix it with a plate and screws. If you look at long-term results, at 5 years out, there's approximately a 75% good result reported. At 10 years out, it goes down to about 50%. So a lot of these patients will go on later to knee replacement surgery in its attempt to buy time, is what it is. So, knee replacement surgery. Everybody's heard of knee replacements. Who's heard of knee replacements here? So there's a partial knee replacement called a unicompartmental knee replacement. We replace part of the joint. It's a metal cap. This is a really hard piece of plastic in between that's cemented in. There's a complete knee replacement. We replace the entire joint. There's a metal cap on the femur here, metal cap on a tibia, really hard piece of plastic in between, and also behind your kneecap, a really hard piece of plastic. So what are the indications for a partial knee replacement? You need to know. This patient has one compartment involved, the medial compartment. So isolated compartment disease. The rest of the knee is not involved. You wouldn't put a total knee in a patient that just has one compartment involved. You have to have an intact anterior cruciate ligament. That ligament runs in the center of the knee. And your deformity has to be less than 10 degrees. So 10 degrees varus, 15 degrees valgus, or 10 degrees contracture. So you have to be able to straighten your knee out, or your leg out, to almost straight. Only 10 degrees can be accepted before we could consider this procedure. So why is a unicompartmental knee replacement more attractive? Well, there's a higher patient satisfaction. It feels more like a normal knee. Part of your knee is left. It feels more normal. There's less blood loss during surgery. There's an accelerated rehab. Instead of being in the hospital 3 to 5 days for a knee replacement, you're in 1 to 2 days. And then we can always convert it to a total knee replacement later. It's relatively easy. So what are the results? If you look at all the orthopedic literature, Pennington looked at 46 of these. Well, at 11 years out, 92% were still in. That's pretty good odds. Price looked at 52. These patients were all less than 60 years old. At 10 years out, 91% of them are still in. So that's pretty good for a joint replacement. So here's an animation just to give you an idea of how it works. So this part of the knee is affected. The cartilage is worn off. The rest of the knee looks okay. And we'll say this patient's 50 years old. So this would be an option for him. So this is a metal cap that goes over the area of cartilage that's worn out. So we make specific cuts on the end of the bones, place a metal cap. Also down here, specific cut, it's a really hard piece of plastic. So instead of rubbing bad bone on bad bone, you're rubbing metal on plastic. Here's an x-ray. Here's a before. You can see an arthritic joint, narrow joint space here. The other side of the knee looks pretty good. Well, this is after a partial knee replacement or a unicompartmental knee replacement. Metal cap, really hard piece of plastic cemented in. So what is a total knee replacement? The most common. Only about 7% of the replacements are partial knee replacements. The rest are complete knee replacements. Well, here's your femur here, here's your tibia. It's a cap that goes on the femur, cap that goes on the tibia, really hard piece of plastic in between. Also behind your kneecap, really hard piece of plastic. So it's the most commonly replaced joint. It's first performed in 1968, so it's been around a long time. And there's nearly 400,000 performed in the United States per year. So knee replacements are considered for patients who have a painful, disabling joint that have failed conservative treatment, that have severe arthritis or advanced arthritis. These patients, in my practice, have failed conservative measures such as injections, anti-inflammatory medications, bracing if indicated. And here's an animation. Here's the top bone, the femur, bottom bone, the tibia. And we make specific cuts on the bones. It's a metal cap, and a really hard piece of plastic in between. And that surgery takes about an hour to do. Here's an x-ray. You can see the metal caps. Can't see the plastic on x-ray. This is the AP view. This is coming from the side or the lateral view. So what's the patient satisfaction? Well, it's typically 85 to 90%. It relieves pain, restores more mobility. How long is it going to last me, doc? Well, at 10 years out, there's a documented 90% success rate where it's still in. So there's about a 1% failure rate a year. And then there continues to be improvements in the materials, especially the plastic. Well, what are the possible complications? You got to know this if you're considering surgery. Well, there's blood clots or thrombophlebitis, and so we use blood thinners. There's an oral blood thinner called Coumadin, been around for a long time. Patients stay on there anywhere from 1 to 6 weeks. There's also the low molecular weight heparins, right? Lovenox, Arixtra. I generally keep patients on those for 3 weeks. And it's a shot. You don't have to have blood draws to monitor the level. Infection. The infection rate is less than 2% if you look at all the orthopedic literature. Stiffness. Well, the knee can be put in perfectly, but you got to get it moving. Therapy is very important. If a patient comes to see me 6 weeks after their knee replacement and they have less than 90 degrees, then I talk to them about taking it through a range of motion to get that motion back, and then trying to keep that motion. Loosening. So after your initial period where you come to see us in the office, I see you back once a year. Take an x-ray. I want to make sure everything's still in the right place. So many patients that could be helped by knee replacement don't know, either from lack of knowledge, misconceptions, or fear. So that's why we're all here talking, trying to educate each other. So how long do patients wait before they see their surgeon? Well, if you look at this, 28% of the patients wait more than 5 years before they see a surgeon, even with pretty severe knee pain. So the over 65-year-old group is the most rapidly expanding segment of our population, okay? So that means there's going to be a greater number of individuals diagnosed with arthritis. There's even an increasing number of younger patients. 36% of our knee replacements are done between the ages of 40 to 64. The average age a patient has a knee replacement is 67 years old. So common misconceptions, well, I'm too young, I'm too active, I'm too heavy. Well, leading causes of failures, the component could loosen. Well, if you're into high impact activities, you want to run or jump, it's not the surgery for you. If you want to try to enjoy your life in a relatively pain-free manner, you want to golf, you want to swim, you want to go to the store, you want to bike, and you have advanced arthritis, I would consider this. A lot of it depends on your surgical technique. The knee replacement has to be in there right. You want proper alignment, you want proper gaps. Infections. An infection can cause a knee replacement to fail. And like I said, the infection rate is less than 2%. Or the plastic could wear out. Well, that's why I see you back once a year. Take an x-ray. See if I see narrowing, that plastic's wearing out. So the goal of a knee replacement implant is to restore normal function of a knee, keep you active, last as long as possible. There's fixed bearing where the plastic stays still, and there's a rotating plastic component, a rotating bearing. If you look at all the long-term studies, the results are about the same. So what's a new option? Well, you see it advertised, computer navigation. What is it? It can help your surgeon more precisely align the knee replacement. And this is what the surgeon's looking at during surgery. We put trackers, go back one, trackers on your leg. Here's your femur, here's the knee joint, here's the tibia. These are tracking devices. And allows the surgeon to see the bones and make proper cuts. So you can make cuts on the end of the bones. You can also balance the gaps between the bones, which is equally important for motion. How it works. It is like a GPS in the OR. Okay, it's infrared technology. Have little satellites, you have trackers. The surgeon has a device where he's putting points that are inputted in the computer automatically. But it can increase your surgery time. Generally increases about 10 minutes if you've done enough of them. The risks are the same as a conventional knee replacement. Well, blood clot, loosening, infection, which we've already talked about. Your individual results vary. Every patient's a little different. The benefits to your surgeon. Well, it provides a comprehensive look at your knee. Everybody's knee is a little different. And we're putting in points from your entire knee to get an idea. It allows us to make adjustments to within a fraction of a degree. And this helps with the correct positioning of the components. So, potential benefits of a computer-navigated knee replacement. It may reduce joint wear and extend the life of the implant. It's relatively new technology. There aren't a lot of long-term studies out there. It may reduce the risk of revision surgery. It could result in greater stability and range of motion. And it ultimately may improve the overall function of your joint replacement. However, there's a lot of debate in orthopedics in regards to this. So what's your recovery after a knee replacement? Well, I got it done. What do I expect? In-hospital stay averages from 2 to 5 days. You'll see significant functional improvement from 6 weeks to 3 months, maximal improvements at 6 to 12 months. So you can improve up to 1 year from a knee replacement. If you have your surgery the first thing in the morning, we'll get you up later that day walking with physical therapy. Okay, and you might just take a couple steps the first time. We want to get you moving. We want to increase your strength, increase your range of motion in that leg. So when can I go back to my normal routine? Well, everybody's a little different. So before you leave the hospital, you'll practice stair climbing. Once you go home, at that 3 to 5 day point, we'll allow you to leave your house as long as you feel comfortable. When can I resume driving a car? Well, if it's your right knee and you have an automatic transmission, it's 4 to 6 weeks. If it's your left knee and you have an automatic transmission, it's 2 weeks. When can I go to work? Well, it kind of depends on what kind of work you do. Generally, I tell patients that they can go back to work about the 6-week point. What sporting events can I participate in? Well, I'll get to that. Not the high impact stuff. Swimming, golfing, fine. Hiking, biking, even tennis. Activities to be avoided. What can't I do, Doc? Well, I really don't want you skiing, because you fall, you could fracture around the component. I've had patients go back and ski that were avid skiers before, but they stay more on the beginner slopes. Basketball, you can't run or jump on it. It's going to wear out. Baseball, well, Bo Jackson had joint replacements. You see what happened to him? They wore out quickly because he's running on it. Contact sports, can't play any more football, sorry. Running, you can't run, nothing with frequent jumping. So how do I know? Well, here's a general guide for acceptable activities. It shouldn't cause pain when you do it. You don't want to place the joint at the extremes of range of motion. You probably don't want to go back and try to do yoga where you're trying to really stretch it to the extreme. And your activities should be pleasurable. How long is it going to last? Well, I told you the data. At 10 years out, there's 90% that are still in. A lot of it depends on your age. The older you are, you're more likely less active. The knee replacement should last longer. Your weight. Remember I told you about the force putting across the joint? Every pound that we're overweight is 3 pounds of extra force on that joint with each step. Activity level. Well, I've talked to you about activities which you can do and activities to avoid. Bone strength. If the bone is weak, well, you have a higher incidence for failure. So these are some of the activities I talked about. Patients go back. They love to fish. You can play tennis, not competitive, but go out and play just tennis, just hitting the ball back and forth is okay. Riding a bike, of course, shopping. It's encouraged for all the ladies. So the number of patients suffering from arthritis of the knee is steadily growing. Of the patients suffering from knee arthritis, nearly half may not seek treatment due to poor information or fear. Well, there's a lot of options out there. Just because you go to a physician doesn't mean he's going to rush you off to surgery. There's a lot of non-operative options also. Patients seeking care are younger, more active, and more demanding. And total knee replacement is a reproducible, reliable, and durable solution for end-stage arthritis. So what do I do? I have so many decisions, all these options. Well, there's the Euflexa injections, that's hyaluronic acid. There's knee arthroscopy. Do I need a partial knee replacement? Do I need a total knee replacement? What do? Talk to your doctor. Make a decision together. Thank you. You want to take questions now or at the end? Dr. Confletti is going to talk next on hips. Well, I'll be here to answer.
One question. I didn't talk about the knee. Would the basics of that, as far as arthritis, be applicable to other joints, specifically like the ankle joint?
Well, if you have an inflammatory type of arthritis, it can affect multiple joints. If it's wear and tear arthritis, and you have arthritis in your knee, doesn't necessarily mean you're going to get arthritis in your ankle.
If the meniscus is torn, can they repair that?
The outer 50% of the meniscus has a blood supply. The inner 50% does not have a blood supply. Now, for patients with moderate to advanced arthritis that have a meniscus tear, like I told you, unless you're having a lot of locking in the knee, the arthroscopy is not going to provide you much relief. It's very common for an arthritic joint to have a meniscal tear. So a lot of my patients will address, if you had moderate to advanced arthritis, you address the arthritis, and that meniscal pain will take care of itself.
You don't want to put together or anything like that.
If you're a younger patient, no arthritis in your knee, and you have a tear of the meniscus, in that outer 50%, we repair it. Okay? And your rehab's a little different. We think it's 6 weeks for a meniscus to heal. It can take longer, but at least 6 weeks. I'll let you put weight on the leg in full extension, but I won't let you put weight and load that knee for 6 weeks after a meniscal repair, because you'll put shear forces on that repair. All right, so like I said, at 10 years out, there's a 90% success rate, or looking at all the literature, that's kind of an average, okay? You know, all the orthopedic companies say their knee prosthesis is the best, and their plastic or poly is the best, all right? They're making some improvements. You know, I tell my patients I want to get 15 to 20 years out of this knee replacement. And if something fails and it's a certain portion, we'd have to go back and revise it.
Have you ever tried bionic on the knee before you had knee replacement?
We've used that some in the past with mixed results. I don't have a lot of experience with it. For patients that you know, aren't operative candidates, or we're just doing conservative treatment, we can definitely try that. I don't have a lot of experience with it, but I have used it in the past.
You have?
Mm-hmm.
Was it successful?
Just kind of grossly, about 50% of the patients say it helped them some. I don't have patients come back and tell me, oh, it took away all my pain. But I haven't, to be honest, I haven't used it that much, but I have used it.
Here you mentioned anything about the wedge in the shoe.
Yeah, that is another option, all right? So let's talk about assistive devices first. Canes. So if you have an arthritic knee and you use a cane, use it in the opposite hand, right? Well, it can take 50% of the force off that arthritic knee just using a cane in the opposite hand. Shoe wedges are also successful. And so you put the wedge and say you have isolated arthritis on the inside part of your knee. Well, you can put a wedge in your shoe to try to change that alignment, okay, and try to transfer some of those forces to the opposite side of your knee and unload that. Similar thinking to an unloader brace.
Is that kind of a test procedure to see what would happen?
Well, it's a conservative option, right? It's avoiding surgery. And we generally trial the conservative things first. The patients that fail the conservative treatment, that can't go live their life and do the things they want to do, then we talk to them about surgery. But that is an accepted treatment, just a simple heel wedge.
In Synovectomy, do you normally use a 3-shot or the 1-shot?
I generally use the 3 shots, okay? There can be some, it's low, but there can be some reaction to the Synvisc or the hyaluronic acid, you know, and I kind of quinge on putting it all in there at once. It's a large injection, so I generally stick with the 3 shots.
I am Dr. Conflitti. I'm a partner with Dr. Davini, and I think I got the hard task because nobody has hip pain, right? Everybody just has knee pain. No? Everybody has hip pain too? Okay, well, thanks for coming today, and we're happy that you all are here. My task today was to try to give you some information about hip replacement, total hip replacement specifically, and some of the newer techniques and technologies that we're trying to use to help those with this condition. Just as a brief outline, I have here what we're going to try to talk about. Some of the things I'll go over kind of quickly because Dr. Vinny gave a nice summary of what arthritis is, and we all know that it's essentially just cartilage breakdown and wear. And so with that said, it can be in any joint, but since we're all upright and walking people, the joints that are most affected, of course, are the hips and the knees. So from there, we'll go forward. And hip replacement has been around for quite some time. In the 60s, Dr. Charnley, Sir John Charnley from Britain is really the one who's really started developing the earliest implants. And since then, so now almost 50 years plus, the hip replacement has been undergoing an evolution in terms of its design, in terms of its placement, in terms of who gets it and who doesn't. And so those improvements have kind of gone by and continue to get better with time. And so even as of 5 years ago, we've had a lot more opportunity to provide those with hip arthritis a better functioning hip, again, to maintain a patient's functionality and to hopefully not allow that to fail at an early age or an early rate. So it is one of the most common joint replacement. It's not the most, but one of. I think knee replacement has now surpassed that. The symptoms of hip arthritis are very similar to those of having knee pain or any kind of joint pain, which is typically startup pain, meaning getting out of bed is quite stiff. You got to kind of really go slow, maybe get in the hot shower, and then it eventually eases away. But then as you use it more and it becomes more symptomatic, then that pain can come back. The typical pain that we see with hip arthritis and hip problems is in the groin and in the front part of the thigh. Now that can be variable. Some people do come in and complain more of buttock pain or more of lateral-sided pain or the side of the hip. And those are the patients that we have to be very careful with because we have to figure out, is it actually coming from the hip joint or is it coming from the low back? Or it could be both. And so we want to make sure that we're providing the appropriate technique and also the appropriate diagnosis so that we get that pain to go away. Stiffness is very common, and weakness is also a very common symptom that I hear from patients, and lack of balance. Some people think that, well, as you get older, you're always off balance, or it's my inner ear, or I just don't have coordination anymore. And in fact, it could be from the arthritis in the joint, whether it be hip or knee, because that will cause a relative muscle imbalance leading to the overall imbalance of the patient. And so hip arthritis can then cause falls, which will then cause fractures. So there's a cascade of problems and issues that can occur that we can all kind of relate back to a cartilage problem. Loss of motion in a hip is kind of end stage, but we also see that as well. You can compensate pretty well with your walk, even if you have a pretty deteriorated hip, because it has such a huge range of motion. And the knee is not as forgiving, and so with patients with knee arthritis, we typically can see, quite a abnormal gait. But in a hip, it has to be pretty late stage before you start noticing any gait disturbance there. So our evaluation is primarily centered around the joint of question, but of course we're going to look at all the joints in that area. So if your left hip is bothering you, I'm also going to examine your right hip, I'm going to examine your back, I'm going to examine your knees and your ankles and your feet. And sometimes patients come in and they ask, well, why do I have to get in these ridiculous paper shorts? You're looking at my hip or you're looking at my knee. But we do that because everything is related. It's not uncommon for me to examine somebody's hip and they have actually very severe flat feet, or they have a deformity in their tibia or in their foot, and that then is the cause of their arthritis. So if we're just treating one joint, you'd miss it. So I want to make sure that I look at everything and make sure that we're really evaluating the whole patient. Many times too, patients have not only hip arthritis, but knee arthritis. And then we have to decide, is the pain coming from the hip or is it coming from the knee? So those are all important things. We look at your gait. I usually have a patient walk in and out of the room, maybe even down the hall and back. We want to check their range of motion. The strength is obviously important. And then we have a battery of tests that we run in terms of x-rays to really evaluate that and look at that narrowing that we saw even on the x-ray of the knee. So our management is, again, just like in knee arthritis. We want to try to manage your pain and help to alleviate the pain. I can't ever say I'm going to take all the pain away, because even with any surgery with a hip replacement or a knee replacement, there's still going to be some discomfort. And so we want to relieve pain and restore function. I think those are the keys to helping somebody with this problem. The options we'll talk about here in a second on what is possible depending on, and certainly individualized upon the patient. And then always, it's the patient's decision. I can't stress enough how often I say when I see a patient that I give them the options. We talk about conservative management, we talk about surgical management, but it's the patient's option to decide for surgery. I'm never going to tell you when you come in, you need a hip replacement. It's not my decision. I can give you the options and I can tell you what would be good and what would be bad. But you have to decide that. You have to know, okay, is this pain so limiting to me that I can't function? I can't do the things I enjoyed normally doing. And also, did we try everything non-surgically? I think that's an important caveat to that, is we want to try those things that have very limited risk, like Dr. Davini talked about, therapy, injections, those sorts of things. But it's y'all's decision, or the patient's decision, to go for the surgery. So as in knee replacement, the non-operative management focuses around getting that balance back, getting the strength back with therapy, whether it be land-based therapy or water-based therapy. And it's variable on where the patient lives, on what we can offer there. Over-the-counter medicines, glucosamine chondroitin is very helpful. I recommend it to everybody that comes through. It does take a month or two to get effective. It can be a pretty big pill to swallow. They now have it in liquid form, and so that's another helpful alternative. Anti-inflammatories can be either over-the-counter or by prescription. They do have the risks, as Dr. Davini talked about. And then by prescription, there are some that have less risk, but they still carry some, especially with acid reflux or indigestion type issues. Other helpful things can be simply a cane or a walker, but that's really not a great solution, especially if you're active and you want to do things. Shoe inserts sometimes can be helpful if you have a leg length problem, so your hip arthritis can be quite severe. One leg might be shorter or longer, and if we can equalize that, that usually helps a little bit as well. And then the injections are not as great as options in terms of hip arthritis as we have with the knee. The joint lubricant that Dr. Davini talked about that's similar to the joint fluid is not yet approved in the hip. And so the only injection that we can do safely is the steroid medicine. And it is something I recommend. It's definitely an option. It provides temporary relief, and it may be enough that the pain is able to be, reasonable in terms of getting around and moving. So, any questions with the non-operative management? I think we kind of went through that pretty nice. Surgical management, and I happen to bring my helpful little model here, and I can even pass that around if y'all want to look at that while I'm talking, but nobody take it or start doing the surgery. Okay, everybody? Because then I'm out of a job. So if y'all want to look at that, it'll come apart. Hip resurfacing, partial hip replacement, total hip replacement are all potential options. And it is very individualized. I'd say the majority involves total hip replacement, in other words, replacing the socket and the ball, because that's usually what is involved. Most people have arthritis on both sides of the joint. The model right here shows what's called a hip resurfacing component, and here it is in a patient. And it is a very nice alternative for younger patients where we want to restore as much bone and keep as much bone as possible, because we know it's going to wear out. So that all of this is still kept. This is your native bone. You actually keep the majority of the ball, and we just resurface the ball, and then that, we think, gives more life to that patient in terms of overall functioning to the hip, so that down the road, if they're 40 when you get this, then maybe at 60 we still can do a hip replacement. But these are all examples. Some are older ones, pictures of, but this is essentially what we're talking about in terms of hip replacement, replacing the ball and replacing the socket. The team, and you see here the team is, we're at the bottom here, because I think there's a whole bunch of folks that need to be involved in this decision. And the first and foremost is, of course, the patient. But after that, then, we rely on your medical doctor to make sure that you're as safe as possible for surgery, that your other medical conditions won't adversely affect the surgery or cause increased risk, because there is definite risk with surgery, as in any surgery. We ask the anesthesia doctors to assist in pain management, so many times we offer an injection in the low back the day of surgery to help decrease the pain. Therapy is, just as in knee replacement, is very critical in restoring the functionality, the strength, the balance, and those people are involved. Pain management, sometimes if there's other issues in terms of low back issues, rehab can be ordered, especially if there are other medical conditions, to really mobilize the patient. Certainly the nurses while you're in the hospital are important, and then finally the doctor that you pick. So it definitely is a team approach. Just as in with the knee replacement, there's a hospital stay, usually 3 to 5 days, of course very variable on your overall medical condition. We do the same thing with knees. We want you to get up and move in the same day. We want the therapist to be at you, and we don't really call them physical therapists, we really call them physical terrorists, because that's what it feels like the first few days. So if the terrorists are on you, then they're doing good, because we want you to be up and moving. Full weight bearing is done usually on everybody. Full weight bearing is appropriate because the components, as you'll see as it's being passed around, are implanted into the bone. So they're nice and solid. We usually don't use any other adhesive, so the bone and the implant are nicely solid, and we want you to bear weight from usually day one. Follow-up, we see you usually at the 2nd and the 6th week, and then 3 months and 6 months, and then yearly, just to make sure everything is going well. And again, the goal is to return to life and to be as functional as possible. So here are the components, and you all can actually touch them there when you get get by. They haven't been implanted in anybody, so don't worry, it's not going to pass along any diseases. But you'll see here that this is the cup right here that gets implanted into the pelvis. This is the pelvis right here. And it has a really thick, roughened surface on it, like a grit blasted. Every company has their own little formula of what is best so the bone grows into it. And then inside the stem, or inside of the canal of the femur, goes this stem. And it too has a grit blasted surface that allows the bone to adhere to it. And then here's where the actual joint is. There's a metal ball and either a plastic liner or sometimes metal liners. I'm sure everyone has heard and seen the commercials about one of the implant companies with a metal-on-metal liner, and that just happened to be one particular brand. But anyways, we'll talk about that in a second. But that's what makes up a total hip replacement. A partial would mean we wouldn't replace the socket. We would leave that alone. And we do that very commonly in patients that have falls and break the top part of the femur, and we put in a partial hip replacement for that reason. We have obviously instruments, and that's so fun about our job. I get to use all kind of cool tools and power tools and things. But there are a number of instruments that are used, and we try to individualize, of course, every patient. So you see here we have different size balls that we use. There are different size necks that go on the stem. And what we're trying to do is balance the limb and balance your hip, make sure your leg lengths are equal, and make sure everything fits in your range of motion. The positioning is typically done with a patient on the side, and that brings up another topic that could be a full other topic, but I'll briefly touch on that. This positioning is called the lateral positioning, where you're laying on your side, and we do the incision from the side of your hip right here. And all the implants go in from that positioning. You can also do it where the incision is slightly back on the back part of the hip, and those are the two ways that are kind of the tried and true ways of putting in a hip replacement. In the last, say, 10 years or so, we have come up with I think, an improved way of putting in the hip replacement, and it came actually from overseas. And now, in certain patients, we can put in the hip replacement from the front. So on the very front of the thigh, about right in here, you can make an incision and put in the hip replacement that way, called the anterior supine position. And the beauty of that is that we don't have to cut any muscles or any tendons. We actually go through the muscle plane. And that surgery for the selected patient is very nice. It usually just 1 to 2 days in the hospital, quicker recovery time, and has been very, very nice. So in those patients, we certainly are using that with very good results. So anyways, lateral positioning is typical, as you see here. And again, we take off the top part of the ball. So as you see it passed around, who's got it right there? You see how the top portion is cut off of the ball. This is the diseased portion of cartilage, bad cartilage, bone spurs. So we make this cut here, and then we put in the cup, and the cup has to be put in. So first we use some instruments to prepare it, and then the cup gets inserted and actually is impacted into the bone, just like you'd pound in a nail into something. We want it to be nice and solid and firm. And then once we're done with that, then we prepare the femur. There are various instruments and tools to make sure that that stem fits directly and nicely and firmly in there. So if you want to take that apart, whoever has it back there, you can actually see that the stem will come out and it fits just perfectly in. So we want that match to be just right. Cementing is sometimes done, but that's only in unusual circumstances. Mainly it's to press fit it in. Then the stem gets inserted. And then the selection of the femoral head and liner, I think, is one of the newer things that have been evolving. We want to make sure that the hip survives, that you have 15 or 20 years just like in the knee. And this is one area of interest from not only surgeons but also implant companies, is what surface is best. So this is the metal ball, and traditionally it's been the plastic liner that goes in. And they've been studying different surfaces. So this is a ceramic ball, and sometimes we use metal on metal, so you can have a metal liner instead of a plastic liner, all with different properties, all with different wear rates. all in the effort and the goal to make sure that that hip lasts as long as possible. And that's something that can be talked about with your surgeon on what his normal thing is, or what are his caveats in terms of patient selection depending on your age, your weight, your activity level. Those are all factors that should be considered. So the final result should look something like that. And the main thing that I don't have on this slide is hopefully up in here there's a happy face, because that's what we're interested in, not just that it looks good on the x-ray, but we have a happy patient. The post-op care is very similar in knee replacement. The complications are almost identical. The only added one on hip replacement is we have the risk of dislocation, because a dislocated hip obviously is a non-functional hip. And so what we try to do is make sure that the range of motion, and if whoever has it there, you can move it around. We want that range of motion to be right where you are living. We don't want it that you just happen to turn a little bit and it pops out. So that is a risk with that procedure, that it can happen. We also give the blood thinning medicine, usually that you have to give at home for a couple of weeks, called Lovenox. You can wear TED hose, and then of course PT and therapy are very key in maintaining and supporting that joint. Again, the goal, to return to life. Just like with knee replacement, really any activity is fine as long as it's not high impact. With the anterior approach, what's also nice is we don't really have any restrictions. So if we were to do it from the front, starting the very first day, you can be up and moving, you can go up and down stairs, you can bend down, you can tie your shoes, you can squat, really anything possible on that one. The other ones have a little bit more restrictions, but that's just for the first 6 weeks. So those restrictions are lifted as the soft tissues do heal. So that leads us then to future advances. And I think it's always going to continue to get better. You know, some patients, like Dr. Vinny said, it takes 5 years to get you in to see what's wrong with the hip or the knee. And a lot of patients, when they finally get there, say, well, how long is this going to last? Or I'm going to wait for another year until it gets better. Well, every year it continues to get better. And the joint replacement companies and surgeons alike have joined together to try to make improvements, as many as possible and as soon as we can, to try to get this to last. So some of the things, like we talked about, different types of plastic that last longer, different types of metal on metal surfaces. Computer-assisted surgery, almost like navigation, is coming to hip replacement as well. Even robotic surgery is in the works, and I think is coming, and all in the goal to get a faster recovery. So I think with that, it does it. Any questions? Yes, ma'am.
Does the bone grow attached to that insert, or you don't have to worry about it jumping out?
If implanted properly, and if you have good quality bone, the goal is for that implant, which has that roughened surface, is to have the bone grow into that surface and it's locked on. And that takes about 6 to 8 weeks to do. Now, as the implant wears, the plastic then is essentially a foreign body. So as you wear and tear that joint, the plastic surfaces start to come off. And when the joint becomes loose, then it loses the bond around where that implant is. Then you start having pain and we got to redo it. Yes, sir?
How much glucosamine do you recommend?
I think the standard is a 1,500 milligram dose. And it can be divided in 2 or 3 times per day. What I usually just say is if you go to the pharmacy, there's all kinds of them. And I would just get the generic version and follow the directions as is. There's so many of them now, it's hard for me to say, well, it's once a day or twice a day. Like I said, they even have the ones now that are liquid, and then you don't have to swallow the horse pill anymore. So, yes, sir?
Since we take these inflammatory medicines, you said there's a risk for them. Would you tell us what some of the risks are?
Of the anti-inflammatory medicines? You bet. The biggest one with anti-inflammatories are it can hurt the lining of the stomach, and it can cause some very severe acid indigestion, and in worst case can cause bleeding ulcers. And so in patients that are susceptible to that, they can take those medicines and end up having bleeding ulcers, and even worse than that, can have very severe bleeding from that. The usual ones, as in any medicine, would be nausea and upset stomach, and you can have maybe some sleepiness. Sometimes you can't sleep. So the biggest one is with the stomach irritation.
I had one doctor said it affected your memory. You know anything about that?
Not specifically, no. The one that went off or several of them went off the market for a little bit, Celebrex being one that's now back, and then another one called Bextra. There was some slight increased risk with causing heart attack, and those drugs went off the market, especially Bextra. But Celebrex came back on because I think it was a little bit of media hype more than anything else. So, yes, ma'am.
Does your body react to a foreign product in your body?
Some patients very rarely can have a metal allergy, and especially to nickel. And nickel is one of the alloys that is used in the implant. It's used in a lot of the implants we use for fractures. That's pretty rare. Now, the foreign body reaction I was talking about before was if you have the implant in, I don't know who's got the implant. Oh, if you have the implant in, you see how the metal goes next to the plastic. The metal is obviously harder, so the plastic then starts wearing off. Microscopic particles. Those microscopic particles the body thinks is a foreign body and starts making an inflammatory reaction. That inflammatory reaction then starts chewing away the bone, which then causes the implant to get loose. Yes, ma'am.
You talked about the wedge in the shoes, and if you have really flat feet, might cause the pain. If we come to you, would you be able to determine that, or do you send us to a podiatrist?
No, we would determine that. Yeah, it all relates together. So not infrequently, if I have somebody come in and they walk, I take off their shoes, take off their socks. If they have really profound flat foot deformity, that can exacerbate or make worse not only hip pain but also knee pain. And if we can correct that, that may be the problem that causes the alignment troubles. And then if we can correct that, then your pain will go away.
Even if you have the arthritis?
It could. Mm-hmm. It's part of a conservative management like Dr. Devine was talking about. Yes, sir.
Yes, my physician prescribed naproxen.
Naproxen? Uh-huh.
It worked great, but why did the insurance company come up and say they're going to quit paying for it?
Good question. That's one of the most common used drugs. It's the anti-inflammatory. It's the drug Aleve, but in prescription strength. So.
And I can maybe, I'm a pharmacist, and I can answer some of that. The insurance companies are out of line completely. They do these things because they can. They want the doctor to prescribe something cheaper.
And there's not much cheaper than Naprosyn, that's for sure.
We fight it every day. And we even have it to the doctor prescribe something, he'll have to give a prior authorization concern that they need that medicine. Now that's ridiculous.
Yeah.
That's what the insurance is doing.
They-
It's strictly them. Money.
Yeah.
Okay?
Let's see. Yes, sir. You, sir.
Is the frontal thing kind of rare, or is it generally available, this newer procedure?
It's generally available. My criteria for that is nobody that's very obese is a good candidate for that. And the reason is you are laying flat on your back and the incision is in the front. If you're quite obese, the belly is in the way for me to get the implant in safely and in a good position. So that's the biggest one. The other one is if you have a lot of deformity in the ball or in the neck portion, so just below the ball, and it's really tight, then it's really hard to get the component in properly. The third one is if you are very, very muscular on the top part of your thigh, again, makes it tough to put in. And the worst thing you can do, I think, is we try a new place to put in the incision and the hip, but the hip is put in improperly. That doesn't do anything for the patient. So if those three are there, or one of the three, I usually will still go back to the lateral approach, which is definitely the tried and true standard of care. It's just that I think the anterior one is becoming more and more popular.
Why is that? Because you go through
You go through, you don't cut any muscle, and the rehab is much quicker. Usually, instead of a 3 to 5 day hospital stay, it's 1 or 2. There's no restrictions from the get-go. With the other, there's restrictions in terms of bending. So if we do it from the side, we're not going to let you do that. We're not going to let you, tie your shoes. There's all sorts of different things. But from the front, you can do all that from day 1. So let's see. Yes, ma'am. You had your hand up for a while.
If the pain you're experiencing is not in the groin, but in like the sacrum area, then this operation is not what's indicated.
That's a difficult question to ask. It's something you'd have to be evaluated for. If there is some question, whether it's the low back or the hip, what can be done is send a patient for an injection in the hip joint. And the radiologists here do that under live x-ray. And I know for sure that injection is getting into the hip joint. If there's no relief whatsoever, then it's not your hip.